Welcome back to the NeuFit Undercurrent podcast. Our guest today is Dr. John Marchese, a chiropractor who's had a practice in the Boston area for 26 years as of the date of this recording. Even though he looks very young, he's got a lot of experience there.
Oh, you're so kind. I wish I had your hair.
And Dr. Marchese's got a lot of experience and very deep knowledge in a few areas that I'm excited to dive into, including functional neurology and both in the realm of rehabilitation, sports medicine, helping people with various neurological diagnoses and challenges, and then also athletic performance. So there's a lot we can talk about along the whole continuum of care here. And Dr. Marchese, thanks for joining us.
Well, thanks for having me. It's going to be fun.
Yes. So you have learned a lot, studied a lot of different curriculums and worked with a lot of different leaders in rehabilitation and performance. And as a kind of way to lead in here, can you let us know for you what has really stood the test of time and what principles or approaches really have become your go-to approaches?
Oh boy. Well, started off a long time ago at this point, and undergraduate, chiropractic school, postgraduate work, I'd say learning the difference between, I should say, schooling and learning, going into the collegiate experience, going to the graduate school experience, and knowing that as soon as you start learning something, having it being almost passionate, then you kind of can look at that and say, well, maybe that's the most important thing. And then for me, the most important thing was probably going into the world of neurology as it is applicable to healthcare, and neurology as it's applicable to performance, injury, recovery, etc. So for me, it's been neurology. It's just an incredibly fascinating, open-ended topic that, we could talk about for hours, but maybe we'll just get about 1 hour on it.
So how would you, let's talk specifically about functional neurology for our audience. For, many people know the term, some know, some of the tests and interventions. Just for people who are in need of an introduction, how would you define or describe functional neurology?
Okay, so functional neurology, let me rewind a little bit. Back in probably 1994, 95, when I was in chiropractic school, me and a few other guys, we were all into checking out different techniques because you're trying to learn what you want to do for the rest of your life. And, people think chiropractic, you're just going to go in there and manipulate a few bones and move on. But the different techniques associated with delivering input into the body as far as chiropractic is concerned can be chiropractic biophysics, neurology, polymer package, so many different things. So we took these VHS tapes, that's how old it was, of Ted Carrick. We put them in there. We saw him doing things, and we're all just sitting around thinking, this guy's nuts. But he's doing a neurological evaluation, and within moments, he's changing a neurological evaluation. So for people that don't know, when you do a neurological evaluation, look at it saying, all right, we're going to find a particular lesion in a particular part of the brain, and we're going to write that down, and then we're going to go ahead and send them out for a further evaluation or further testing, etc. Or Dr. Carrick showed that you can just go ahead and actually make a real-time change there, reevaluate and show that neurological change. Well, that's functional neurology, and just watching him doing everything from different types of manipulation to the ribs, adjustments to the neck, back, from a whole different perspective, meaning you're doing nothing more than putting input into the system in order to change the neurological evaluation. And so that's when the test becomes a treatment. When you think about it, if I have a dysmetric finding, right, my hands to my nose, and then I put an intervention in, and you think, well, what am I really doing there? Because if it's dysmetria or past pointing, I'm thinking, well, I have a cerebellar disorder. But then you put an intervention in there and you change the finding instantaneously. Did I now just fix the cerebellar disorder? Okay, so that's how functional neurology works. Did I fix it, or did I just open up a pathway through which I can now have a therapeutic exercise intervention, a training intervention, eye movements, pick your modality, some type of multimodal input into the central nervous system that makes that change, and then gives them the ability to go ahead and keep driving that change until it becomes a permanency. So functional neurology is just an evaluation that everybody else would do from a neurological perspective, but then keeping in mind all the time how that you can change it using interventions, multimodal, exercise, vibration, whatever you want to, NeuFit, different frequencies, etc., and then changing it and making those changes last and become plastic.
That's awesome. That's a great description. Thank you for that. And I really like the part of your description where you talk about how the tests can be the same as what a traditional neurologist might do or traditional neurological evaluation might be or assessment might be. But then to make those changes in real time, that does seem like the big step forward in functional neurology. And to be able to get precise where the test becomes a treatment. If you're doing a test for the left cerebellum and you have some sort of deficit, and then you can do that to drive more activity, increase function in that same left cerebellum, it creates the opportunity to make changes there. So that's great. And the test, you mentioned a few, you could be looking at eye movements, you could be looking at different things. What types of testing are you doing on the neurological evaluation? I know it's a very broad question, but what are some of the kind of main or most common ones?
So the most common ones that I'll probably start with. So going through all the coursework in chiropractic school, you're taught a neurological evaluation. You're taught to be, productive. You're not going to start with a person in lying down position, put them into a standing position, put them into a seated position. So you'll go through, depending on the patient, of course, if they can stand. So I know you've worked with a lot of MS patients, as have we. So you put a person in the position of most comfort, and you start with that. If they're in a seated position, you can test cerebellum, you can test eye movements, you can test, how about just postural assessment from a standing position? You can test long tracts of the spinal cord, both ascending and descending. You can test cranial nerves. Through cranial nerves, you can test eye movements, you can test hearing, you can test sight. You can test, well, how's their sensation? How is it to fine touch? How is it to stretch? How is it the pressure? Checking all of these different mechanoreceptors to find out if the brain is actually, if the scouts for the body are actually giving the right intel back to the brain, and is it giving the right output? And there's the whole idea of primitive reflexes, which I love. So I know a lot of people will be really fast to jump towards the vestibular aspect, the eye movements and all this stuff. But if you have a person that has retained primitive reflexes that they've never actually suppressed and moved on from, you can't really expect great things until you get rid of those first. And that's a whole mitigation strategy that if you don't test for it, you don't know if they're present, then how you're going to go ahead and move on from just primitive reflexes. I mean, those can be huge, especially in people with MS, post-surgical. I just had a post-surgical lady who had two primitive reflexes pop up after her hip replacement. She wasn't making any progress with physical therapy, and go figure, she had an atonic neck reflex and she had a spinal glide reflex retained. And instantaneously, she thought I was a voodoo guy because we just changed those reflexes. And all of a sudden, she was able to hip abduct and adduct when her therapist was saying, well, we just got to get these stronger. Well, you can't outwork a dystonia. You can't do it. So if you improve the tone by getting away from those primitive reflexes, all of a sudden the brain can make the contact without too much threatening going on. And well, she thought it was pretty cool. And that's probably why I do it, because it's cool and it makes the rehab so much easier for me, but also for her therapist. So we can have a collusion between the two therapists.
That's awesome, man.
A little rambling, but.
Well, it's great. I mean, it's a good overview of what a neurological evaluation looks like. If people are listening to this and they're more in the orthopedic and sports medicine realm, they may, they certainly are not doing, most of them are not doing these types of evaluations or assessments on a daily basis. Or for people who are interested but haven't gotten the training, it's good to hear the range of different tests that you can do. And there are different types of things that you look at from different brain areas, cranial nerves, spinal, primitive reflexes, spinal reflexes. I mean, all the different layers and levels of the nervous system. And then
retest and test and just see your real-time changes.
Yeah, for sure. So in that sports medicine orthopedic realm, for you, this is going to be a bit of a silly question, but I want,
There's no silly questions.
I want to ask you, all right. So how many of your, quote unquote, simple orthopedic patients, like you mentioned this, post-op hip replacement woman. So, for example, how many of your, quote unquote, just, typical orthopedic pain patients come in, have findings on a neurological assessment or neurological evaluation that are directly impacting their pain and orthopedic issue.
100%. Legitimate 100%. You can't throw a person in here into this practice and not have us find something that will directly impact it, because there's nothing in the body that isn't impacted by the brain. And, is there such a thing as a simple orthopedic problem? So I love it when people come in and say, well, I jumped up, I went to head the soccer ball, I came down, and my right ACL ruptured. Okay, well, why did your right ACL rupture? Why didn't your left ACL rupture? We already have a complicated neurological picture going on right there. Well, did you land more on your right leg? Did you land more on your left leg? It doesn't matter, because predictability of injury is neurological, because your neurological pattern or the neurological pathways that you utilize the most are the ones that are going to dictate what happens to you. I mean, everyone's trying to predict injury, right? Ever since they came out with the FSM, right?
Mhm.
I can't remember the name of the guy who came out with it a long time ago, right? Ever since then, they've been trying to predict injury. And ever since then, as far as I can tell, injuries have gone up. We have endemic hamstring injuries, endemic ACL injuries, endemic everything. Because listen, I have a small practice, right? I like to say I'm a bit of a ham and egger, which means that essentially I see my patients and that's it. I'm not affiliated with universities or anything like that. But for God's sakes, would somebody please do a neurological evaluation with the predictability model for non-contact injuries and repetitive injuries? Because somebody's got to do it. Because as far as I'm concerned, that's the missing link, is the neurological profile of an athlete gives you the predictability for their injury. And that's it.
So if someone were to do that, do you have a hypothesis on what would stand out the most in terms of what, if any, particular deficits might lead to certain injuries, or would it be a range of certain things? I mean, what do you hypothesize would happen in a study like that?
Well, I'm more of a cerebellum fan. I know some people have their favorite parts of the brain. My favorite part is definitely the cerebellum, which is in other circles would be pretty goofy for someone to say you have a really favorite part of the brain, because the cerebellum is like that big, and the rest of the cortex and neuraxis is much, much larger, but yet the cerebellum has more cells. Would that then tend it to be more important? The cerebellum has almost 4 times input towards the cerebellum as it does output from the cerebellum. So it's always listening, it's always gathering information, and it basically makes us athletic as far as I'm concerned, and probably as far as a lot of other people are concerned. So I would look towards a cerebellar examination and then get a formatted, I guess you could say, evaluation where that we can test for tonal output to the posterior chain, anterior chain, et cetera, and whether there are feedback, feed forward, efferent copy type issues going on with the cerebellum. If I know a movement and I go to perform a movement, then it should happen the way it was programmed into my brain, with the communication between the frontal cortices as well as the cerebellum. So that should happen. But why all of a sudden doesn't it happen? And why all of a sudden does a person step, turn their head, and blow their ACL? Why does a person step, get a rebound, turn their head, and rupture their Achilles? Little things like that. So if I look at the neurological evaluation, right, and I look at the downregulation of the brain and what it's supposed to be doing to our, let's say, ventral horn, where you send a message down, crosses over, hits the ventral horn, goes into the end organ. And if that end organ is a muscle and it has to respond quickly, so if I step and I move and my hamstring is supposed to go ahead and fire with my quadricep, push me off into a particular direction, why is it that hamstring would go ahead and fail and allow for that anterior translation of the tibia to blow the ACL? Well, if we look at some of our neurological evaluation predictive modeling, if we have a reduction in, let's say, neocortical activity on one side of my brain, okay, neocortical frontal structures, some parietal structures, et cetera, things that make us human, I can have a reduction in volitional activity on the opposite side of my body. So if I go to perform a volitional movement and I can't access those ventral horns very well because of, let's say, I head the ball with the right side all the time, and I've had multiple concussive activities or events on the right side of my brain, and it's just a little bit slower. So that generation of increased activity in the ventral horn on the left-hand side can't transmit the the message fast enough that it needs in real time to play a sport, to get those hamstrings afire, to decelerate that tibia, well, I've got an ACL injury. Or if I'm a sprinter, the same thing happens if I can't decelerate my hip flexors on the ipsilateral side. I'm pushing off, all of a sudden, pop, I have a labral tear. All right, and then we start fixing these areas surgically, rehabilitative wise. And the way to go ahead and fix those usually is to perform some type of an invasive procedure. That invasive procedure now cuts through the layer of the fascia. Your stiffness is now gone. And where do you have to put the emphasis of that incision? It's got to go up or down. And if it's in the back, it's got to go up or down, a little bit to side, but it depends on the person's major movement, right? So then we start having a predictability model of about the hockey players that have their labral tears. Go in, get it repaired. Next thing you know, hernia, lumbar spine injury, disc herniation. Keeps happening. So if things keep happening, study those, look at the evaluation, correlate the evaluation to the injury process. It really can't be that difficult. If we've been doing it for a long time, other people should be able to do it. If you don't measure something, you don't have an evaluation, then you can't see if it's going to get better. And then you can't go and have any predictive modeling based on that. So that's, kind of what I would like to do, but we'll see. We have our own little case studies here.
Yeah, for sure. I mean, the big theme that really emerges for me hearing you speak is the concept of really getting to the root cause, that if someone has an underlying neurological deficit, is not engaging their muscles properly, then they're at risk of these injuries. And that's part of why we see these non-contact injuries that you describe. And this is a way. So why, you mentioned you've been doing it in the functional neurology community for years. And, we teach elements of this. I mean, in NeuFit to all practitioners, we don't have as
level 2.
We have,
is that your level 2 seminar?
We have, there's elements of this. It's not nearly as sophisticated as what you're teaching. And the scope of a functional neurology evaluation, or the scope of what you need to know to be able to evaluate people in different circumstances, is a lot. Do you think that is the barrier for why it's not more widely adopted? Is it the amount of material information, or is it something else? What do you think?
I don't think so. I think it can be really simplified. Because most of the athletes, why does everybody want to take care of athletes as far as rehabilitation goes? Because they're so easy. You've got this incredible central nervous system. What's easier, working on a person who's had MS for 3 years, or a person who's had, let's say, chronic knee pain for 3 years? And give me the chronic knee pain any day, because the neurological pathways are still intact. There's no white matter lesions or anything that are going on. So chronic knee pain, just find the reason for it. So as far as your question goes, the evaluation for an athlete doesn't have to be as extensive as the evaluation for the person with MS. The evaluation for an athlete doesn't have to be extensive for the person who has, ALS. So you can bring it into a coordinated system where you're looking for particular traits of that athlete. And you can modify it a little bit for a hockey person. You can modify it a little bit for a track and field person based upon, their sagittal explosive activity, more of a multiplanar athletic pursuit. So our evaluation is, I can do a full evaluation in a half hour on an athlete and have a good idea as to what's going on in their brain. And people who do personal training, they'll take a half hour with an FMS. Like the FMS is okay. It's going to give you an idea of how high they can lift their leg, how far they can go ahead and what's another one? Oh, the overhead squat, all that stuff. I did it many years ago. And if you look at it from a perspective of just how well they move, that's fine. But if I'm looking at it a perspective of what's wrong with my proximal hip flexors on this right side, is it, do I just have a little volitional weakness here? Or is it maybe a red nucleus thing on the contralateral side, because all the muscles are in response to a part of the brain? My hip abductors, if I'm going into a lateral lunge, or if I'm like when we do muscle testing, I think muscle testing is an incredible tool that is so misunderstood, because everybody says, well, there's no inter-examiner reliability, blah, blah, blah. Well, if you get good at it, God forbid you have to practice something to get good at it, right? Then all of a sudden you can pick up the subtleties. What's the difference between testing someone for resistance and having someone push into you? It's the difference between tonal output and volitional output, right? So everybody should be doing 2 types of muscle, and everybody should be doing muscle testing as far as I'm concerned. But if you can go ahead and figure out whether a person has an input, contralateral input issue from volitional activity or ipsilateral tonic input, you're way ahead of 99% of therapists right now and trainers. And then you can send your program in the direction that you have to. Like I listened to your podcast, I think it was a couple of podcasts ago when you were talking about the McMaster study and not having to load the body so much in order to go ahead and generate muscle hypertrophy, right? And then, but why don't people do that now? Why is it that every training center that you go into is doing heavy weighted bilateral movements? If you've got an imbalance that hasn't been detected at a neurological evaluation and you load both sides and you're driving both sides of the brain, you ever think that the one that's a little bit better might overstimulate compared to the other one a little bit? And if you've got a great cerebellum on one side and maybe a cerebellum that's a little reduced in its firing on the other side, you ever think that functional training might be causing dysfunctional athletes and contributing to our injury process? So that's why I think every trainer, every therapist, every what have you, athletic trainer should do at least a baseline neurological evaluation to find out what that their athlete, client, patient, etc., should be doing from point A to point B to point C. You can't guess because it's not your body. So I guess people don't mind if they're just doing it to somebody else. But if it was your body, I would want to know. Like knowing what I know from my history of learning, et cetera, I would want to know. So to have that baseline neurological evaluation can direct your care. Plus, it also directs what you're going to strengthen. Different parts of the brain, different types of exercise work better for different parts of the brain. If I've got a kid who's got ADHD, let's just throw a neurological term, a reduction of saccadic activity from, let's say, left to right. Okay. Do I want to do some type of an exercise that's going to stimulate his frontal structures? Well, yeah. So what exercise stimulates frontal structures? What exercises stimulate parietal structures? Then there are actual resources out there where you can look that stuff up. Frontal structures, I'm looking at. What do you guys like doing? Isometrics, right? You're going to do a hard, and people are like, well, why would isometrics work? Well, why would a focusing activity work on a kid with ADHD? And what is an isometric? Or should I say a micro, what's the new word? Micro eccentric concentric.
Yeah.
Right. Just leave it, call it an isometric. What the heck? You don't have to be that clever. So why would that work for them? Because you're stimulating their frontal structures because you're getting them to focus.
Yeah.
So that's what I'm talking about as far as a neurological evaluation, being able to go into multiple systems.
That's awesome. One point, there's so many good ones, so many gems in there. One good one I just want to make sure to emphasize is the notion of training symmetrically or bilaterally. I think there's a good saying that you have to earn the right to train symmetrically or earn the right to train bilaterally. And if also, if someone has an asymmetric issue, it does need to be addressed asymmetrically. And so doing unilateral training and being more intelligent about this, I think is a really, really kind of low-hanging fruit way to make training safer and more effective. And if you couple that with, like you said, with a basic neurological evaluation, that can be a recipe for changing population wide, like among, averages, among athletes, among sports and age groups. There could be a recipe for really making some major demographic changes. So I like that a lot.
Well, if you train unilaterally, right, then you want to, if we want to do, let's say, a single leg squat, right leg in front. And we think, all right, we do an evaluation and we notice that there's a right side hemisphericity, which in functional neurology would mean just a reduced frequency of firing in particular structures on the right-hand side. So do we then utilize like a Bulgarian squat concentrically? Do we hold an isometric on that right side? Like what part of this right leg that we consider to be, let's say, deficient, measurements, et cetera, what exercise do we use on that single leg? Because you can do a single leg exercise and still further the imbalances because you don't know what that leg needs, what tract, what end organ that you're trying to stimulate. So the unilateral training is better, but also having the knowledge of what that limb needs as far as its stimulation to the opposite side and ipsilateral side is even more important. So we can take it even further, which now we're going into rare earth.
Yeah. And it's incredible to me the precision with which you can like one of the things you mentioned, at the beginning of our conversation here was when you were watching these videos of Dr. Carrick back on the VHS tapes about
Yeah.
about how he was making adjustments, and a lot of people in chiropractic and outside of chiropractic look at that and think, oh, we're physically moving these structures here and there. But one of the breakthroughs is, no, when we're giving that input, it's actually giving very precise neurological input to certain parts, certain pathways in the spinal cord, certain areas of the brain, changing activity there. So these adjustments are more than just physical or tissue, more than just affecting tissue, they're affecting the neurology.
Absolutely.
And the same thing with exercise. You can get very precise in terms of different movements, like you mentioned, a lunge versus a split squat versus a unilateral pistol squat. Those can all have different effects in different parts of the brain, which could make, enhance or enhance or depress certain areas of the brain. And the precision there is amazing. So if people are hearing this and thinking, I would like to learn more about this, about how to really add in functional neurology, what are your go-to resources? I have a couple thoughts there, but I'd like to hear from you for sure.
Find a functional neurology doctor first off, because they're usually really open to talking about things, because in the chiropractic profession there's a lot of different approaches.
Mm-hmm.
Functional neurology guys are usually, I would say, the lowest number, because it is kind of a difficult thing to achieve is to work with functional neurology. So we like to talk. Can you give me 1 second? The talking part I did all morning, my throat's a little bit off. So
of course.
Let me go do a little cough here, okay? Okay, sorry about that. Had to go and have some whiskey on a Friday to clear my throat a bit, being a Bostonian and all. So how to find out more about it? Well, functional neurology doctors love to talk, as you can tell by listening to this podcast at this point. Call a guy, look up on their websites, find out what they do. If you have any questions, I'm sure they'd be more than happy to talk to you about it. As far as other resources go, I mean, YouTube is another resource. I'm sure people are always showing things online in order to go ahead and promote their practices and such. Social media, I guess, but I would always go to the source first. I would just call up a functional neurology practitioner. And there's functional neurology chiropractors, but there's also some physical therapists that have learned it, some athletic trainers. And now there's some personal trainers that have learned some information on it as well, and acupuncturists. So you can go ahead and speak to any of these people at any time. I'd be more than happy to talk to people about it. And it's a very small world. It's like the hockey world. You and I have talked about this before. Hockey world is a very small world, and they're very willing to help each other out. The functional neurology world is the same way. It's a small world and always looking to help each other out. So that's what I would try.
Absolutely. And I know you and I have talked a little bit in the past. We haven't seen each other in person since pre-COVID, but
yeah, that was my second to last trip before COVID too. Yeah.
Oh yeah, that's right. So we might have to replant the seed of doing a continuing education course together here on some of this stuff, because
that'd be a blast.
Yeah, I know we talked about it a little bit before, and then both got busy with other things, but that
all pandemic.
Yeah, right. That's right.
What a world.
So let's shift and talk a little bit. You kind of already in the last few minutes here talked a little bit, progressing along the continuum of care from rehabilitation into training and performance. From a neurological perspective, it's really interesting. You mentioned one example of how bilateral training can potentially reinforce imbalances and problems. What are some other things that stand out to you that are commonly done, but actually can be detrimental or can reduce performance or increase the risk of injury?
Okay, so if we're looking at increasing risk of injury, again, looking for a good predictive model, well, the biggest predictor of injury is previous injury. So if you can figure out why that previous injury occurred and why that previous injury keeps occurring over and over and over again. See, people are funny. One of the facilities that I worked with up here back in the late 90s, early 2000s, is where a lot of the, let's say, soft tissue manipulation world started, okay? Foam rolling, lacrosse balls, tennis balls, hit your head over the bat, that kind of thing, right? One thing that people have to understand is that pain isn't good. And that's really hard for people to understand because we've been now conditioned that tightness is bad and pain, as long as you're doing it to yourself, can be a good pain. As far as I'm concerned, there's a thing in neurology called the labeled line principle, okay? If I press button A, it goes into a part of the brain where button A goes to, and that's it. There'll be a little bit of an offshoot, okay? Maybe 25 to 30% of it will go to other places, but if I'm pressing this receptor, it's going to this part of the brain. If I cause pain, there will be a specific reaction to that pain. And it's never really good. You know, you don't go in and get maybe an aggressive soft tissue massage, for example. Oh yeah, I sweated through 2 t-shirts during that session and I was sore for like 3-4 days. But after that, oh boy, did I feel good. Well, did you, or did you maybe activate an injury process at this point? So when you go into a gym and every day you foam roll and you got to suffer through your foam rolling, or you got to suffer through your lacrosse ball work. And then after that, you go ahead and you just do an aggressive stretch that is just, again, miserable. You're coupling pain on top of pain on top of pain. To me, this is what has caused the majority of, I don't want to say injuries, because to say injuries would say that, you know, you foam roll, you stretch your hamstring, you go out there and you blow your knee. That's not necessarily always true, right? But to go ahead and cause the nagging injuries that cause us to compensate from one bad pattern to the next bad pattern to the next bad pattern to injury. You see what I'm saying? In guys like Hans Selye used to say it was what, 6 to 8 weeks approximately to go ahead and develop a compensatory pattern. Well, if your quad's always tight and you're rolling out your quad all the time, then you're stretching out your quad all the time, all of a sudden your quad's not tight anymore, so the foam rolling must have worked, or the cross ball must have worked, the stretching must have worked. But then all of a sudden, gee, now my hamstring's always tight. Oh, and now I can't go ahead and get that 40 time that I got, 6 weeks ago. Or now let's look at the gait. Now my left shoulder hurts, right? Or now my neck hurts, and now I can't expand my rib cage, right? Little things like that can occur. Was the foam rolling good, or did it lead into a compensatory pattern? So pain, to me, and previous injury are both probably the biggest ones that were going to contribute to a person having an injury. And if people would just, so I grew up in the 80s, right? When everything, you're tight, dude, I'm tight, look at that, hey, tight. But nowadays, oh, I'm so tight. Let me roll the heck out of that thing so I can get my biceps. Oh, look at that, my range of motion is back again. So if I do things like that all the time, and whenever anything's tight, instead of listening to it, I just cause it pain. And of course it's going to elongate, because what happens when you cause pain to a muscle? What's the reflexive activity that's going to cause? You increase nociceptive activity, whether it's type C fibers or 1A, W1A deltas. Excuse me. And when all that information goes up to the brain, it's constantly going up to the brain. I know that when you press here and cause pain, it's not going to cause a reaction up here. It's actually a lifting of the down regulation of paying attention to those nociceptive fibers, right? But if you're always driving it, the brain's going to pay attention. It's going to say, well, maybe something's going on over there, and I got to pay attention to this thing. And what's it going to do to that muscle? It's going to assume the worst, because that's what the brain does. And it's going to protect you. And how's it going to protect you? It's probably going to reduce your frequency of firing of that muscle. And if it reduces the frequency of firing of that muscle, and you don't use it as much, whether it's consciously or unconsciously, what happens to that muscle in the cerebellar and the prefrontal strip homunculus, right? It goes down a little bit, that frequency of firing. And next thing you know, I'm out there and I'm a pitcher and I'm throwing, and I'm like, oh God, I'm getting a little tightness in my shoulder now, right? Throwing again. And what do people do? Well, let's stretch it out. Let's get those posterior shoulder muscles working again. And in reality, it has nothing to do with the posterior shoulder capsule, but it has everything to do with the fact that someone thinks they're tight and they've got to keep rolling out their bicep, forearm, etc. Okay. And then that will be your predictive model. And instead of going ahead and then looking at that arm and saying, how many pitchers you're going to have to see that can't throw six innings anymore before you figure out a neurologically predictive model for dead arm? You know, we got a guy up here that should have been seen by you guys a long time ago, right? And hopefully he will be seen by you guys because you went ahead and you made the trip up to Boston, right? So hopefully they'll be looking at this and listening and saying, oh, Garrett, thank you very much. You're going to get us another 22 wins this year. But that's the whole thing. For me, it's pain, causing yourself pain, which nobody should ever cause himself pain, and looking at previous injury. I don't know if that helps at all.
Yeah, for sure. For sure. That's interesting. On the topic of also, you know, things that we do that might have unintended consequences. Tell us your thoughts on the Airdyne bike too.
The Airdyne. Oh boy, this lost me a lot of fans. Let's put it that way. Not that I ever had. So if you look at it, let's take hockey. All right, where is the fan bike prevalent mostly? It's probably going to be in hockey and small training centers. So I go ahead and I take a guy whose gait center is already disrupted, right? Because when the foot hits the ground, that's when it all starts. And as you know, being a hockey guy, when you play hockey, you have to get your foot into a position of pronation to get that inside edge to push off with, right? And the boots that you put your foot into are pretty tight, but you can still get that arch flattened down. We usually start skating between ages 3 to 5. My kid will probably be like 5, but 3 to 5, you get that foot pronated down there, get that inside edge and push off. Well, in mechanics, when you're running on the ground like a normal bipedal human that we are, instead of an abnormal hockey player, you're going to use a supinated foot to push off with. So you're generating force with a pronated foot or a supinated foot. So the gait is already disrupted. Then you take these guys and you put them on an Airdyne bike or a fan bike where they do this. I don't know if you can see that, but this right here, push, push, push. And what does that look like? That looks like a Muppet walk, right? This is what we call it when patients come in. We do a Fukuda test, part of our neurological evaluation, right? And a Fukuda test is evaluating gait center integrity. And gait center, you know, you get brain stem and spinal cord, you've got midbrain, and you get cerebellum. You got a whole bunch of different places that you're looking at. So when a person closes their eyes and they say, okay, march in place one. And I see this.
So for people who are just listening, what he's demonstrating is we should have a contralateral gait, right? When the left arm, when the left leg comes forward, the right arm comes forward, opposite arm, opposite leg, and he's showing an ipsilateral, the opposite, where it's same arm and same leg are moving. So yeah, like a Muppet walk, and that is a problem. Is less energetically efficient, less biomechanically efficient and effective. You know, creates an issue. So please continue. Just wanted to make sure everyone listening.
Sorry about that.
No, yeah, all good, all good.
So if we lose that, then you start talking about things. I'm a big Sergei Grakovetsky fan ever since I heard him talk back at the first fascial conference here in Boston. And his idea of the spinal engine, keeping the integrity of the core musculature going via contralateral patterns, right? And he goes into the idea that these ipsilateral patterns are great as long as we're quadrupeds. But for bipeds, we need, and quadrupeds obviously walking on 4 legs, okay? Bipeds, we're human, right? We're bipedal. We should be walking on 2 legs with 2 arms, reciprocally moving in ways that are going to go ahead and mirror our lower extremity. In kinesiology or in neurology, we call these the gaits, okay? So when you get on a fan bike and you keep perpetuating, and the key is if you're on a fan bike and you're just going for a nice little easy ride, right? No big deal, not a lot of strength of stimulus and not a lot of frequency, because that's what drives neurological changes. But if you get on there and you're using that as your primary source of conditioning at a high frequency, because you're doing a lot of reps and a very, very high strength of stimulus, you're making a neurological change. If you're teaching the body that it's okay to go into that ipsilateral pattern and make those changes all the time, you're going to lose a lot of integrity of proximal hip flexors, proximal hip extensors, proximal shoulder flexors, proximal shoulder extensors, and how they coordinate through the core musculature. And that's a given. And you want to see an epidemic of injuries in hockey, it's hip and lower back, right? Do you know a hockey player that doesn't have a hip issue? I mean, I think you even had a hip issue.
That's right. Yeah.
Point 2.
Absolutely.
And if you want to break that habit, getting people off of that ipsilateral pattern on the fan bike might be a good idea. I mean, how hard is it? If you're going to buy 6 bikes, right? And this goes back to the conversation we were having before. Yeah, 6 bikes are great. Go ahead and put them in there, but just don't use them all the time. Use them for warm-ups, etc. But don't use them for your high intensity activity. There's no need for it. And then the other part of it is fix the feet. If you got a guy going from skating all the time and you want to give him some higher intensity activity as a hockey player, I mean, you ever watch hockey players run? It's painful. They all look terrible. Not all of them, most of them look terrible. So if you go ahead and you start getting into, like we were talking about before, different techniques and such, we've been working on hockey players' feet in preparation for off-season training, just so they can do a high intensity work like sprinting and running and intervals and such like that. So that way they can get into that contralateral pattern, keep their proximal muscles working well with their core muscles with good integrity within the feet. It's not an easy way of doing it. It's a little bit more involved, but that way you don't keep hurting athletes.
Yeah, that's a great insight there. And it's really interesting when you look through a neurological lens, how some things that we may take for granted or that are very commonly practiced, turn out to have some other issues. There's another side to another perspective there for sure.
There's a major perspective when it comes to looking at things from a neurological lens, and it's kind of it's a beautiful thing, but it's also a curse.
Yeah.
Now you see a lot of things that are consistent practice for 30, 40 years in strength and conditioning, and you wonder why people keep doing it. When whether you've spoken with them, when you've pointed things out, etc. But people will still stick with what they've always done because sometimes it's just really difficult to change. And I like to say we can't really blame people for not wanting to change because they've always done it that way. But sometimes, when you start seeing that one kid that's a soccer player, that when you talk to her and you talk to her strength coach and you told them to limit certain things and they say, well, you're just a bleeping manual therapist, and they go ahead and do it. And then a few weeks later, she blows her ACL and a non-contact injury. When you get 26 years of that crap, you get a little sick of it.
Yeah.
I mean, after a while, these poor kids, they're trusting these professionals and they're paying a lot of money to these professionals. And, maybe they should just go ahead and do a little bit more of their due diligence and taking care of these kids. I can tell I'm getting older and I can tell I'm a new father and all that stuff, relatively new father, because now I'm getting a little more adamant about getting these kids to speak up for themselves. So.
Yeah, well, it's interesting when you talk about this notion of, well, we've always done it this way. It's difficult to change. There's a couple elements in order to change. One, there has to be enough pain with how things are going currently to motivate change. And I think that is present. There also has to be the knowledge that something can be done differently, or the openness to possibility, understanding that there is a possibility to do things in a different way. So I think it's finding the people who are dealing with these non-contact injuries, or coaches who are frustrated with the endemic of non-contact and the trends there, and then being able to reach those people who have the frustration to let them know there's a better way. It seems like that's got to be some of the recipe. But in terms of
when you see a guy on the biggest football stage, right, going to run across a field and turn his head and have a non-contact ACL, you ever think that there might be something towards the turning of their head that may have led towards that non-contact ACL? Why not at least test for it?
Yeah.
How hard can it be? I was at a conference. This is going way back. This is when a guy named Art Horn was doing this Boston performance, whatever it was, seminar series, right? I remember talking in front of all these big strength coaches from all over the world, right? What I was doing there, I have no idea, but I was talking to them anyways. And I go through the whole idea of testing the cerebellum, etc. This guy comes up, raises his hand. He says, "I will not do this with my patients." And he was from a foreign country. And I said, well, why not? He said, well, because I don't believe it will help them or anything like that. I said, that's perfectly fine. You can do it or not do it. And he's telling me about how he has this great soccer player, and he's never going to do a test with them. Well, that greatest soccer player a few weeks later blew his ACL. And in one way, I thought, how long would it have taken this guy to just do that little bit of testing right? That little tiny bit of testing, maybe 7 minutes worth of cerebellar testing to find out whether or not maybe he should focus on one side or the other for this one person, right? That 7 minutes could have changed one poor fellow's career, right? That, as opposed to just, I would never do this, you know, you got to subvert your ego sometimes and just allow for people to, I guess, succeed even without you necessarily having to say, I'm the person that made them succeed. You know, most people succeed because it's intrinsically within us, you know, within an athlete, they're going to succeed whether or not they've got the greatest strength coach or not. You know, we talked about that too. You could be a great hockey player, get a mediocre program, you're still a great hockey player. So why not give them a little something that might keep them playing a sport for a long period of time? Just subvert your ego and learn something new. That's all.
There is.
Look at the NeuFit, right? I mean, how many people, everybody should have a NeuFit unit. Everybody. There's no question in my mind. After doing this stuff for 26 years, you know, the neurology obviously is a huge part of it. But the addition of direct current therapy, it makes it almost easy. I feel like I'm cheating. I go to work and I'm like, all right, what horrible thing is going to walk into the office today that we're going to fix in like 3 days, you know, in 3 visits. And I don't want to say that because they're not all like that. But for the most part, it's like cheating. That's how good it works. And for people not to have it in their clinic, I mean, God knows I don't want a lot of people in Boston to get it because, you know, competition is competition, but there's a few million people here. I don't have to worry about that. You know, I'm only one person. I can only see, you know, 15, 16 people a day. But there's no doubt in my mind that has been one of the biggest additions that I could have ever, you know, asked for, was getting into the direct current therapies, you know, going all the way back to the old units, the old chiropractic units back in the late 80s, early 90s. Granted, there were some mishaps, you know, it might have been a little burning here and there with those units because they're not as safe as yours, you know, but the results were great. So I just wanted to throw that in for sure, because that makes the idea of functional neurology that much easier as well. Because if we're trying to access a particular mechanoreceptor and change these, you know, dynamic range mechanoreceptors within the spine and into the brain, et cetera, what better way to do it than finding a particular frequency to go ahead and stimulate the brain, the end organs, everything else. It's just so much easier. So it's been invaluable as far as my functional neurology practice goes, is utilizing it, you know, and the old FSM protocols that you guys use, you know, people think that's crazy, but the results speak for themselves. So I don't know. If I'm going to make my job easy, I'm glad you made it easier. That's all.
Well, it's a wonderful collaborative effort here, and you know, thank you for that. I agree. Every clinic should have a Neubie, certainly. And you know, picking up on that, what you described there about using the Neubie device, and then also the theme from earlier about how when you look at things neurologically, you have to do things differently.
Yeah.
How would, you know, with the Neubie, there already is an element of functional neurology because we're trying to look for where the nervous system, where these compensatory movement patterns are with mapping, trying to find where there's excessive tension or inhibition, try to reset those protective and guarding mechanisms. So there's an element of functional neurology inherent already in kind of what we call our level 1 or our basic programming. But for people who are using the Neubie out there specifically already have, you know, using basics with mapping and doing foot baths and doing different things, how would you say that you apply it differently? You already touched on it a little bit, but how would you say you apply it differently or in a more detailed or precise or effective way by combining it with some of these deeper understandings of functional neurology?
That's a good question, because the same way any interventional device like the Neubie or any other type of exercise, et cetera, biofeedback, neurofeedback that we're going to use, where you can make somebody that much better that quickly, you can make them that much worse that quickly as well. So if I have a typical, one of the orthopedics that we work with says, he goes, I don't really know what he does, but you're going to go in there and I know your right knee hurts, but it'll probably work on something on the opposite side of your body. So let's say you go to a practitioner and they map that right knee without doing a neurological evaluation, right? They find the hot spots, they give you the exercise, and then you go back, they come back the next time and say, geez, my knee's been, terribly sore for a couple of days now. Is that supposed to be how it happens? Oh yeah, don't worry about it. It'll be fine. Then you get it done again. They come back again like, geez, my knee is really, really sore. Is that supposed to be how it happens? And this keeps going on. And then you realize that you didn't do a neurological evaluation. And if a person has left cerebellum, for example, and let's say right parietal lobe. So they've got this big, big old representation of that right side, okay? Because that's the injured side. And then you keep increasing that activity. Well, if I increase upstream activity by putting, let's say, the NeuFit on my right side, because it's a right knee problem, but I don't know that they need input from the left side because I didn't do my neurological diligence, then I can actually take that right knee. And all of a sudden, this is what happened with, there was a clinic up the street from us here. I won't mention the name, but they had about a 40% success rate utilizing the direct current device because they didn't do their due diligence neurologically. Putting it in the hands of a person that doesn't know the nervous system. That's why it's great that you guys did a level 2, because you're going to cut out a lot of that crap, right?
And for the record, the other clinic he's mentioning was using a different device too. So I know.
Oh, absolutely. It had nothing to do with NeuFit. You know who I'm talking about, right?
Yeah.
Killed miserably. Luckily, we got a lot of those patients. But for example, if you don't know that they need to, like when you guys talk about doing bilateral points, well, the good thing about the Neubie is you also get 2 channels. So you can use a specific frequency on one side and a different frequency on the other. Let's say I have to drive this left side with greater strength of stimulus and greater frequency in order to make a better change. Well, I can still put it on this side, lower strength of stimulus, lower frequency. So I'm not driving it as strong on the left side, I'm driving it stronger on the right side. Thus, I'm getting all of that down regulatory activity I want from the right side without boosting up the left side too much. So it's kind of a win-win for both sides of the brain and both sides of the body. So that's why also knowing the neurological system is kind of important. So whatever you can do that makes great improvements, you can also make great detrimental changes as well. So
that's right. With great power comes great responsibility.
Huge responsibility. Absolutely.
That's right. Yeah. And that's why mapping the uninjured side also and looking for asymmetries is a big part of what we teach, because you will pick up some of that. Of course.
Muscle testing.
Yeah.
When you guys muscle test, you test the right side, the knee hurts, and everything you test is strong. Then you go to the other side. Well, put the current on the other side, because that's what the muscle testing is telling you. And then we talked earlier about different types of muscle testing, right? Testing for volitional action or testing for tonic action. That's one of the big things that we learned in, applied kinesiology and clinical kinesiology is testing for that part of the brain. People think those techniques are kind of wooish, but they're not, because they're actually looking at the neurology. If I'm testing an AV ductlet, am I testing a glute med, or am I going to test the vestibulospinal tract? If I'm testing the hip flexor, am I testing the rectus femoris, or am I testing the rubrospinal tract? There's a difference. If I'm testing for tonic output from the contralateral side, or if I'm testing for just plain old volitional activity, there's a big difference. So you have to use different types of muscle testing for that. And then that can also direct your Neubie placement. So you don't go ahead and make the wrong decision. You put something on the left shoulder, all of a sudden the right hip pain goes away. People think it's crazy, but it's not. It's neurologically based, in reality.
Yeah, absolutely. And it's amazing when you work with the nervous system, how quickly you can make changes. Fortunately, most of the time they're positive changes. And
most of the time,
we're doing this. And it's really powerful. And, as we're going through this, I imagine many of the people listening are going to want more. So we can talk offline, but I would be definitely interested in doing some more content together and being able to share this with people who can then take this and become even more effective by being able to do some of these neurological evaluations and
when I'm not so scattered going off in directions. Well, I never said I didn't have ADHD, so let's put it out.
Well, we'll get you doing some ISOs, and then then you sit down at the computer and write out a few things. That's good.
Yeah, I've had a lot of ISOs in the past few days. Working out beautifully for me.
That's good. Yeah. So that's why you're so dialed in right now. I love it.
Oh yeah, a little bit. We also use some biofeedback machines. We use color, we use sound, light therapies, metronomic activity. So all that stuff is also contributing to, good activity in our patients and ourselves. You got to kind of practice what you preach. And I know you do. So.
Absolutely. Absolutely. Yes. Well, this, a wonderful conversation here, and I think a very compelling tour around the universe of functional neurology. So I appreciate you coming on the show here. If people want to learn more about you, what's the best thing to do? Look at your website. You do have a social media page, I know.
Yeah, we do. I get yelled at to put stuff on it every once in a while.
That's right. Yeah.
Because I'm like that short of a boomer at this point. So yeah, we do some social media stuff. Let's see. We have.
Is it Marchese Sports Therapy?
Yep. And we have a website, marchesesportstherapy.com. And yeah, just, I guess, look that stuff up there. And we're always open to conversations for people. And, maybe someday and I keep saying this for the past 20 years, maybe someday we'll do some teaching. And we'll see what we can do.
That's right.
Integrating all the stuff. It's
at Marchese Sports Therapy, all one word.
Yeah.
Pulled it up here, make sure it wasn't an underscore or anything, but
no, there's not that many Marcheses out there.
That's right. That's right. Certainly none as wonderful as you and as knowledgeable in this realm, for sure. So,
well, I can say a lot of big words, but sometimes you got to put it into the small words for people, because that's a better idea that you know what you're talking about.
Yeah, for sure. Well, we covered a lot of detail here, and a lot of people may have questions. So I think there would be value in breaking it down and doing some more teaching here. So that's something that we've planted the seed today, and we'll talk more about. And in the meantime, thank you everybody for tuning in here. I hope you enjoyed the conversation with Dr. John Marchese.
Yeah, thanks everybody.
We appreciate you listening in, and we'll see you on the next episode of the NeuFit Undercurrent podcast.